The number of psychopharmacological treatment options has exploded over the past few decades. There are now approximately 120 distinct molecules, not slight variations on the same compound, but genuinely different chemical entities currently approved and available in the United States market for the treatment of psychiatric disorders. And if we consider the variations, meaning the same molecule but in a different delivery form, say an injectable version, a long-acting injectable, a transdermal patch, a sublingual tablet, an intranasal spray, or an implantable device, that number climbs to well over 200 formulations. Now compare that to the non-pharmaceutical or physical approaches to treatment. These are much less numerous. We can name them because they are few: electroconvulsive treatment, or ECT, transcranial magnetic stimulation, or TMS, vagus nerve stimulation, or VNS, deep brain stimulation, or DBS, light therapy, transcranial direct current stimulation, or tDCS. That is roughly 6 modalities. And then, of course, there are the psychotherapeutic approaches. The American Psychological Association recognizes over 400 varieties of psychotherapy, from cognitive behavioral therapy to psychodynamic therapy, from EMDR to dialectical behavioral therapy, from motivational interviewing to schema therapy, and hundreds more. So the treatment options in psychiatry is vast. Now here is where things get really interesting and really sobering. Consider the fact that in clinical practice the combination of 2 or rarely 3 pharmacological agents is extremely common, and each of these combinations should be considered a distinct treatment strategy. If you have 120 medications to choose from, the number of possible 2-drug combinations is over 7,100. The number of 3-drug combinations is over 280,000. The number of 3-drug combinations is over 280,000. The numbers grow at astronomical levels, and we have not even considered the dosing variations, sequencing, or timing of each agent. But of course, very few of this astronomical number makes clinical sense, but the number of distinct combinatorial medication strategies are still in thousands. Practically impossible for any clinician to ever use them all in their career. Unfortunately, what goes beyond one medication used at a time is virtually uncharted territory, and it will remain that way for a long time to come. There are few proper studies looking at what combinations of 2 medications do together, but combinations of 3 or more cannot be studied with research strategies that are considered solid enough to justify clinical practices. And the reason is simple. The combinations of 3 or more medications explode in numbers, and the cost of studying these options in properly designed randomized controlled trials makes such research essentially impossible. No one is going to fund 280,000 clinical trials. So what happens in practice? Especially in difficult cases, 3 or more psychiatric medications at the same time are not uncommon. And all these situations practically revert to a more simplistic approach. We treat symptoms. We add medications to target one symptom, then another to target a different symptom, and we largely ignore the presence of the other medications already on board, unless in very rare circumstances we are aware of a specific pharmacokinetic or pharmacodynamic interaction. The choice of what to add, what to combine, has to be based on knowing the mechanisms of the medications we use and making some logical inferences from that knowledge. And I want to be honest with you, this is a crude approach in medicine. It is not evidence-based polypharmacy. It is educated guessing, but it is the best we can do with the tools and evidence available to us. Now, let us go back to the total number of unique molecules. Approximately 120 currently not only approved, but actually available on the market for the treatment of psychiatric disorders. It is really impossible to remember all of these names. And here is the additional complication. For every single one of them, there are actually two names. There is the brand name or trade name, which is the name chosen by the pharmaceutical company for marketing purposes, Prozac, Abilify, Xanax, Seroquel. And then there is the generic name or the chemical name, which describes the molecule itself, fluoxetine, aripiprazole, alprazolam, quetiapine. So if a clinician needs to be familiar with 120 medications, that is actually 240 names to keep track of. And this number only grows with every new approval. So how do you organize this chaos? There are several classification systems. The first and most traditional one is classification by indication, meaning what problem the medication treats. This is the primary system used in clinical practice, and it gives us the following major classes: antidepressants, antipsychotics, mood stabilizers, anxiolytics, sedative and hypnotics, stimulants for ADD, anti-addiction agents, cognitive enhancers, and anti-movement disorder agents. I should mention here that some medications are members of several of these classes because they treat more than one condition. Quetiapine, for example, is classified simultaneously as an antipsychotic, a mood stabilizer, and a sleep aid, depending on the context and the dose. Inside of each of these indication-based classes, there is a second level of classification based on chemical family or mechanism of action. So within antidepressants, you have SSRIs, SNRIs, tricyclics, monoamine oxidase inhibitors, and atypical agents. Within antipsychotics, you have first generation, second generation, and third generation drugs. There is yet another classification system based on mode of administration. The vast majority of psychiatric medications are oral, meaning they must be taken by mouth. Then there are intramuscular injections, both short-acting and long-acting injectables that can last from 2 weeks to 6 months. There are transdermal patches. There are sublingual and intranasal formulations. And there is a very thin group of implantable devices which are surgically placed under the skin. Let me briefly describe the trade-offs between these delivery systems. Oral medications are non-invasive, easy to adjust, self-administered, widely available, and generally the most affordable. Their disadvantage is that they require daily adherence. Then they undergo first-pass metabolism in the liver, which can reduce bioavailability. They can cause gastrointestinal side effects, and they are easy to forget or simply stop taking. Intramuscular injections, particularly the long-acting formulations, ensure adherence because the patient does not need to remember to take a pill every day. They bypass the gastrointestinal tract, they provide steady blood levels over weeks or months, and they are ideal for patients who struggle with adherence. On the other hand, they require clinic visits for administration. They can cause injection site reactions. You cannot quickly adjust the dose once it is given. They have higher upfront costs, and they are limited to only a handful of specific medications. Transdermal patches offer steady absorption, bypass first-pass metabolism, and are good for patients who have difficulty swallowing, but they cause skin irritation. Very few psychiatric medications are available in this form, and some, like the selegiline patch, come with dietary restrictions related to their monoamine oxidase inhibitor activity. And finally, implantable devices offer the longest duration of action, sometimes months, and they essentially eliminate the adherence problem entirely. But they require a surgical procedure to insert or to remove. The options are extremely limited. You cannot quickly reverse the effects if there is a problem and there is a risk of infection at the implantation site. Now let's look at the major classes one by one with some examples. Antidepressants. Within the SSRIs, we have fluoxetine, known as Prozac, sertraline or Zoloft, escitalopram or Lexapro, paroxetine or Paxil. The SNRI include venlafaxine or Effexor, duloxetine or Cymbalta, desvenlafaxine or Pristique, and levomilnacipran or Fedzima. The tricyclic antidepressants include amitriptyline or Elavil, nortriptyline or Pamelor, imipramine or Tofranil, Parnate, Selegiline, and its transdermal patch known as MSAM, and isocarboxazid or Marplan. Among the atypical antidepressants, we have bupropion or Wellbutrin, mirtazapine or Remeron, trazodone or Desirel, and vilazodone or Vibrid. And then there are the novel agents, the newest arrivals, esketamine nasal spray, marketed as Spravato, now approved as monotherapy for treatment-resistant depression, brexanolone, marketed as Zulresso, an intravenous infusion for postpartum depression, zuranolone or Zurzuvae, the first oral medication specifically for postpartum depression, and gepirone, marketed as Exua, a serotonin 1A receptor agonist. Antipsychotics. The first generation, also called typical antipsychotics, include haloperidol or Haldol, chlorpromazine or Thorazine, flufenazine or Prolixin, and perfenazine or Trilafon. The second generation or atypical antipsychotics include risperidone or Risperdal, olanzapine or Zyprexa, quetiapine or Seroquel, aripiprazole or Abilify. The third generation, which are partial dopamine agonists, include brexpiprazole or Rexulti, cariprazine or Vraylar, lumateperone or Caplyta. A truly novel mechanism arrived recently with xanomeline combined with trospium, marketed as Cobenfy, the first muscarinic agonist approved for schizophrenia, representing the first genuinely new mechanism for psychosis in decades. And the long-acting injectable antipsychotics include paliperidone palmitate, marketed as Invega, Sustena for monthly and Invega Hafiera for twice-yearly formulation, risperidone in its long-acting forms Uzedy and Risperdal Consta, and aripiprazole, Loroxil, or Aristada. Mood stabilizers. The classic is lithium, available as lithium carbonate, marketed as Lithobid, and as lithium citrate in liquid form. The anticonvulsant mood stabilizers include valproate or Depakote, lamotrigine or Lamictal, carbamazepine or Tegretol, and oxcarbazepine or Trileptal. Anxiolytics. Among the benzodiazepines, we have alprazolam or Xanax, lorazepam or Ativan, clonazepam or Clonopin, and diazepam or Valium. The non-benzodiazepine anxiolytics include buspirone or Buspar, hydroxyzine or Vistaril, gabapentin or Neurontin, and pregabalin or Lyrica. Sedatives and hypnotics. The Z drugs include zolpidem or Ambien, Zaleplon or Sonata, and S-zopiclone or Lunesta. The orexin receptor antagonists include surovexant or Belsomra, lemborexant or Dayvigo. The melatonin receptor agonists include Rameltion or Roserem and Tasimeltion or Hetlios. Stimulants and ADHD medications. The amphetamine-based agents include mixed amphetamine salts or Adderall, lisdexamphetamine or Vyvanse, and dextroamphetamine or Dexedrine. The methylphenidate-based agents include methylphenidate in its various forms, such as Ritalin or Concerta, dexmethylphenidate or Focalin. The non-stimulant options include atomoxetine or Strattera, viloxazine or Qelbree, guanfacine extended release or Intuniv, and clonidine extended release or Kepvei. Anti-addiction agents. For opioid use disorders, we have buprenorphine combined with naloxone or Suboxone, methadone, naltrexone in its monthly injectable form marketed as Vivitrol, and naltrexone implants. For alcohol use disorder, we have naltrexone Revia, Camprosate or Campral, and disulfiram or Antabuse. For nicotine use disorders, there is varenicline or Chantix and the various nicotine replacement therapies, including patches, gum, and lozenges. Cognitive enhancers used primarily in dementia and Alzheimer's disease. The cholinesterase inhibitors include donepezil or Aricept, rivastigmine or Exelon, which is available both as an oral formulation and a transdermal patch, and galantamine or razadine. The NMDA receptor antagonist is memantine or Namenda. And more recently, the anti-amyloid monoclonal antibodies have arrived, including lecanemab, Leqembi, or donanemab or Kisunla, both given as intravenous infusions. Anti-movement disorders agents, specifically for thyroid dyskinesia, the VMAT2 inhibitors, include valbenazine or Ingrezza and deutetrabenazine or Austedo. And finally, some emerging and miscellaneous agents worth mentioning: psilocybin in advanced clinical trials for treatment-resistant depression through the COMP 360 program. Combination products like olanzapine with semidorphan, marketed as Lybalvi, which aim to mitigate the weight gain associated with olanzapine, and dextromethorphan combined with bupropion, marketed as Auvelity, a rapid-acting oral antidepressant, and the anticholinergic agents used to manage extrapyramidal side effects such as benztropine or cogentin and trihexyphenidyl or Artane. I should emphasize that many of these medications belong to multiple categories. The atypical antipsychotics, in particular, crossover extensively. Quetiapine and olanzapine are used to treat depression, bipolar disorder, insomnia, and psychosis, depending on the dose and the context. Gabapentin straddles the anxiolytic, pain, and off-label mood categories. Now I want to close with the observation that I think it's critically important and that rarely gets enough attention. While the number of treatment options is substantial, pharmaceutical companies and insurance companies make sure that the vast majority of patients in this country will never have access to the newer medications. The reason is the ridiculously inflated price of medications in the United States. Brand-name psychiatric medications routinely cost thousands of dollars per month. A course of Spravato treatments can exceed $5,000 to $7,000 per session. Long-acting injectable antipsychotics may run $1,000 to $3,000 or more per dose. And insurers erect systematic barriers, prior authorizations, step therapy requirements, formulary exclusions, outright coverage denials, all designed to steer patients toward older, cheaper generics, regardless of clinical need. The United States government still refuses to do what every other developed nation does, which is to meaningfully regulate the price of medication and stop the exploitation on one of the most vulnerable segments of the population, people suffering from mental illness. Every other developed country negotiates drug prices, caps out-of-pocket costs, and ensure that when a clinician determines a patient needs a specific medication, that patient can actually get it. In this country, the government watches as pharmaceutical companies charge whatever they want, and insurance deny whatever they want. And the people who suffer the consequences are those who are already suffering the most.